welcome to the Department of Internal Medicine Grand Rounds. This is the last session for September, the fourth or fifth session for this year. Thank you all for coming back. Today, just a couple of housekeeping issues. We are still all virtual, and so if you have a question or a chat, please use the chat function or the Q&A function of the webinar and submit your questions, and our speakers will leave some room at the end to help answer questions, and we would appreciate it back and forth. We also have the ability to unmute individual rooms or audience members. If you want to ask your question in person or via audio, please let us know. You can raise your hand and we can allow you to unmute you. So for today's session, I'm joined by Dr. McIntosh and Dr. Marcelo. Today's talk is titled Understanding Diagnostic Errors. It's part of our MMI Conference series for the Grand Rounds. So I will start by introducing the speakers and then turn it over to them. Dr. Georgia McIntosh is an associate professor here in the Division of Hospital Medicine at VCU. She received her medical degree at Pennsylvania State University College of Medicine and completed her residency in chief here in internal medicine here at VCU. She's an avid educator and has completed her graduate certificate in medical education and previously served as a core educator in the internal medicine residency program and director of the hospitalist pathway. She has been awarded Outstanding Ward Attending by the House staff and most recently earned the 2020 Leonard Toe Humanism in Medicine Award presented by the Arnold P. Gold Foundation. Recently, she has been appointed the Associate Chair of Quality and Safety for the Department of Internal Medicine and maintains a strong interest in academic, hospital medicine, quality improvement, patient safety, and medical education. Welcome, Dr. McIntosh. Dr. Carolyn Marcelo is an assistant professor here in the Division of Hospital Medicine. She received her medical degree in West Virginia University and completed her internal medicine residency as well here at VCU. She's interested in medical education and was the past Grand Rounds Director for 2 years, from 2019 to 2021. She currently works as an academic hospitalist and has been recognized as an excellent educator, teaching in PCM class as well as on the wards. She has a particular focus in quality and safety and recently assumed the role of quality director for the residency program. Welcome, Dr. Marcelo. I will go ahead and turn it over to you all, and I think Dr. Marcelo is going to get us started. Thank you so much for joining us today.
Thank you, Dr. Bergman. Thank you for attending for the audience. So this is part of our quarterly Morbidity, Mortality, and Improvement conference. We're going to be talking about understanding diagnostic errors, which is, I find it a bit daunting in terms of understanding all the factors that go into why errors might happen. And so our goal is to hopefully understand some of that and do this in a way that hopefully will spark some interest as well as give the audience some tools in terms of what they can use in the future. For our MMI, Morbidity, Mortality, and Improvement Conference, our goal is really to learn from errors or complications that have happened and unanticipated outcomes that might have happened with our patients. Of course, we want to make sure that we engage all members of the team, our faculty and our learners, in a conversation about this, either a critical incident or a near miss. And really, we want to diagnose system errors, things that we can improve upon from our system, rather than point fingers at individuals, as we're really striving for that just culture in here at VCU. And of course, we want to increase any transparency regarding efforts that might be happening. And our goal is to continue to spread that information. I put an asterisk here because our system, when we talk about diagnostic errors, it's actually more complex than just the system. That actually we talk a little bit about the clinician. So there might be some aspects of individual clinician factors that might go into that. And we'll talk about that later on. The ground rules are the same for all of our MMIs. So we really want this to be a way that everybody can put themselves in the viewpoint of the person or the team that is taking care of that patient. So really we want to avoid any finger pointing. Try to put yourself in that person's viewpoint. So use I wonder statements as opposed to they should have statements. We make sure that there are no identifiers. So if you were involved in this patient care or know somebody that was, definitely make sure that we keep things confidential. And above all, we want to make sure that we identify any fixes in our system or tools that individuals might use that can help improve care for our patients in the future. So our objectives for this specific talk, diagnostic errors, so we want to recognize how diagnostic errors really impact the both the individual patient, but as well as the healthcare system at large. We also want to define diagnostic errors and the factors that contribute to those. And then the third piece is to identify any tools that might help to reduce diagnostic error. Dr. Marcelo and I have no conflicts of interest to disclose. So just to give you a heads up, we actually have a question, some audience participation using Mentimeter. So if you want to get ready for that question, you could use the QR code or use the link menti.com with the code below. As we go into description of our cases, at the end, we'll have a question just to spark some thoughts or conversation about those cases. So before we get started into our discussion, I just wanted to give a framework for the folks that are doing this and really understand how we got to where we are now with our quality and safety group. So I'd be remiss if I didn't acknowledge the really groundbreaking work and foundational structure that Dr. Sarah Hartigan put into place for this group of folks that are doing this quality and safety work here in the Department of Medicine. For those that didn't know, Dr. Hartigan was the Quality and Safety Associate Chair for 10 years and really helped to put this group of folks together with learning and collaborating with the performance improvement and patient safety group in the hospital. We have a number of different folks that I want to make sure that you guys know because they're doing really great work behind the scenes. So our medicine group is really grouped in terms of our hospital medicine, house staff and digestive health, and pulmonary critical care divisions. So for hospital medicine, our quality director is Dr. Stephen Biederman, and he co-chairs that QAPI with Mallory Mendiguez. For our house staff and digestive health QAPI, that's co-chaired by Dr. Carol Marcelo, who's in this role in July 1st, and she co-chairs it with Nina Carter. For our pulmonary and critical care division, that is led by Dr. Kristen Miller, who co-chairs that QAPI with Audrey Roberson. And then for our hematology, oncology, CIT, and palliative care division, that's co-chaired by Dr. Mary Helen Hackney with Vicki Olson. And then for cardiology, co-chaired by Dr. Hayne Bardwaj and Angie Carneal. This July, we actually added a new quality improvement director for rheumatology, allergy, and immunology, and that is Dr. Rabia Gill. So this whole group really does that work of leading QI projects as well as analyzing safety events in our department. So just to give a little bit of background of what we're seeing in terms of the numbers and the types of safety intelligence reports. So from 2020 to 21, this bar graph gives a sense of what we see when we see the reports that you guys fill and what categories they land into. So this has been fairly much consistent in terms of the trend. Medication-related issues are always our top opportunity for improvement, whether it be patients getting the wrong medication or medications that are not dosed based on their renal function or wrong timing. This is, definitely our biggest opportunity for continued improvement. Second of which is the care coordination and communication aspect. And one of those big projects that you heard about last year was the paging and escalation project led by Dr. Stephen Biederman, really looking at how pages are sent, if they have the components that are necessary for the receiver to really understand what's going on. And they did a big project to identify and analyze those pages that's now taken over by the health system at large. So really proud of that work. But one of the things that we don't always focus on is diagnostic error. So the omission, errors in assessment, diagnosis, and monitoring. As you can see, for 2021, we've had 180 cases that are identified there. And that's not to say that it's not very frequent. I think it's just hard to really understand when an error in diagnosis really happens and if that led to a serious safety event. But I think it's still something that deserves attention. And then just so that you know what we are seeing in the Department of Medicine. So we also, our goal of course is to reduce our serious safety events. And that's one of the fiscal year 2022 goals, is really to reduce that serious safety event ratio. Of course, the goal is always to have zero serious safety events. For the medicine group for this past year, we've had 16 for HEMONC 2 and cardiology 3. So definitely opportunities to improve, but continued work in communicating that and communicating the action plans that we've developed with our patient safety team. So that's kind of the background. So we're going to dive into these 3 cases. All of them are similar, and they all happened within the past academic year. So 3 cases of new onset weakness that were on the Department of Medicine. So the first case, going to go through these quickly. 62-year-old female, history of end-stage renal disease on dialysis, sarcoidosis, osteoarthritis, obesity, previous history of uterine cancer, bipolar disorder with history of psychotic features and schizophrenia. Her chief complaint was subacute worsening dyspnea and cough. She reported having soreness of her chest from a frequent cough, and actually went to an outside hospital, was diagnosed with a cracked rib. Unfortunately, we don't have the records from that outside hospital, and this was her verbal report. But she woke up on the day that she presented with weakness and reportedly unable to stand. She specifically denied any back pain and denied any trauma, and admitted that she frequently has trouble with achieving her goal dry weight in dialysis. Her exam was notable for rhonchi throughout, and on neuroexam had 5 out of 5 strength in her bilateral upper extremities, but 1 out of 5 in bilateral lower extremities with intact sensation. Her labs were notable for potassium of 5.6, a white count of 9.8. Her chest X-ray did show mild pulmonary congestion, and a CT of her L-spine showed no disalignment or dislocation, no acute fracture. She did have disc bulge at L4, L5, and L5, S1 with suspected degenerative disc disease. She also was found to have a 1.9 centimeter mass on her right kidney. So she was admitted to medicine for hyperkalemia and volume overload. The ED and the admission note noted weakness of her legs, and specifically no concern for cauda equina syndrome, as she had no pain, no numbness or tingling, and no bowel or bladder dysfunction. And specifically, they noted that there was low concern for a stroke as the weakness was bilateral. They did order an MRI, and neurology was consulted. On initial neurology evaluation, their differential included possible vascular pathology, maybe a spinal stroke or aortic dissection. They also included epidural abscess, although noted that the lack of back pain made this less likely. and possibly malignancy. She did have a history of known uterine cancer and had a mass on her kidney. And so at that point, they recommended an MRI of her CT and L spine and considered a CTA to rule out any spinal vascular defect, although they did note that that would be rare. So on the following day, neurology reevaluated the patient and noted that her symptoms were somewhat waxing and waning as opposed to more acute. And they actually noted that her weakness had improved. So at that point, her differential was reprioritized to progressive peripheral polyneuropathy. And they no longer were really concerned for a spinal cord infarct or a mass. And so recommended to defer further neuroimaging with an MRI at that point. And so the MRI was canceled. The timeline after the patient was admitted, on hospital day number 1, the team had ordered the MRI, but was unable to be performed because the patient was unable to lie flat. On hospital day number 2, it was noted that her symptoms were somewhat inconsistent, and so the MRI was canceled based on neurology recommendations. On hospital day number 4, as her symptoms were persistent, there was concern that maybe there was some conversion disorder or somatoform symptoms. They actually consulted psych, but psych did not think that that was part of their constellation of symptoms and recommended outpatient follow-up. By hospital day number 5, as her symptoms persisted, they reordered the MRI and found a T5, T6 discitis with osteomyelitis. Patient underwent emergent laminectomy and resulted in incomplete paraplegia. For our second case, this was a 66-year-old man, history of hypertension, substance abuse, and chronic hip pain due to osteoarthritis. His chief complaint was pain after falling downstairs backwards with resultant left shoulder pain, neck pain, and headache. Notably, he is not on any blood thinners and reported no loss of consciousness. His exam, musculoskeletal exam, was notable for no obvious defects or swelling. He did have tenderness over his left scapula, but there was no step off or tenderness of the T or L spine. On his neuro exam, he had intact upper extremity strength. 5 out of 5 of the right lower extremity, but 3 out of 5 of the left lower extremity, and noted reduced range of motion of the left arm due to shoulder pain, but specifically no focal deficits of that left arm with normal sensation. He got multiple imaging, including a CTA of his chest, his head, and his neck. Notably for his neck, he did have retrolisthesis of C3 on C4 and C4 and C5 with some degenerative disease and osteophytes and some evidence of cervical central and femoral stenoses, but no acute fracture or trauma. The patient was discharged home with plans for follow-up with ortho, but returned the next day with increased neck and back pain and admitted to heroin and alcohol use at home due to the pain. His exam was unchanged at that time, but because of the abdominal pain, he did get a CT of his abdomen and pelvis that did reveal a large lower paraspinal lumbar spine hematoma. So he was diagnosed with a contusion and whiplash, was given anti-inflammatories, and discharged home. He returned the third time. He actually never left the emergency room waiting room after the second discharge with persistent body aches, abdominal pain, and headache. His exam was notable for pain on exam, but no focal deficits. His labs did show that he had a 2-gram hemoglobin drop, and so they repeated his CT of his abdomen and pelvis. With contrast, showed stable size of his paraspinal soft tissue hematoma, but no evidence of active treatment. Labs, they did do hemolysis labs that were negative. A repeat head CT was negative. He did have 1 episode of hematemesis, a small amount in the ED, and so was admitted to medicine. And on our timeline, on hospital day number 1, due to that decrease in hemoglobin, IR was consulted for possible embolization of that large hematoma at that paraspinal site. However, as there was no active bleeding, there was no intervention recommended. Hospital day number 3 was noted that he had persistent back pain, and so a CT or MRI, the C and L spine was ordered. And by hospital day number 4, he was noted to have progressive weakness of all his extremities. The MRI of his C-spine was obtained, and it showed a rupture of his ligamentum flavum at C5, C6 with hematoma. So he required an urgent discectomy and fusion, and resulted in incomplete cervical tetraplegia. And then case number 3, 63-year-old man with a history of AFib on apixaban with a recent pericardiocentesis of unclear etiology, which is at an outside hospital, complained of an unwitnessed syncopal event while he was working, was bending over, sustained a head lat. Labs and studies showed a no acute fracture or subluxation, and thoracic aorta CTA had no trauma and cardiomegaly. He was initially admitted to trauma surgery. However, while there, complained of acute left arm immobility. And so a stroke alert was activated. CVA was initially obtained that was negative. And so because of concerns for possible syncope contributing to his head lag, he was transferred to medicine for continued evaluation. While on medicine, had persistent left arm immobility, but no evidence of acute CVA. And so an MRI of his brain and C-spine was ordered. That was eventually completed, and it showed an epidural hematoma with impingement on his spinal cord. He went for emergent laminectomy and evacuation and had resultant C5 tetraplegia. So this brings us to our audience participation section. So go to Mentimeter and answer the question link there. So the first question is just a test question, but really our question is, what factor contributed to a diagnostic error in all 3 of these cases? I'll give you a minute to answer those questions. So this is great. I think it's fairly equal. So yeah, I think that this is a great way to frame this conversation. So it looks like people thought of system-based factors as well as clinician factors fairly equally, but fairly equal between at least those top 3, patient-specific, system-based, and clinician-based cognitive factors. So when we look at what our actual patient safety team did in terms of a stream analysis to look at all 3 cases, they actually found fairly similar findings that you guys found. So this stream analysis is really looking to identify areas of value as well as areas of non-value added events or tasks in this system, and really identified the same things that you guys did. So So the cognitive factors, those thinking about patients with weakness and really having a broad differential, but also prioritizing what that differential looks like. System-based factors, so understanding that we have delays in getting studies that we want for our patients in a timely fashion, but also patient-specific factors, so potentially disorders that the patient might have, or any challenges in terms of presenting that patients might actually present with, as well as sometimes we have environmental factors that might contribute to patients not getting the things that they need in a timely fashion. So this brings us to how do we really understand the impact of diagnostic errors in our healthcare system. I'm going to turn it over to Dr. Marcelo.
Thank you, Dr. McIntosh. So why should we talk about diagnostic error? Addressing diagnostic error has many challenges. Diagnostic errors occur in all settings of healthcare, inpatient, outpatient, nursing facilities, and many other practices. Diagnostic errors can occur in evaluating both common and rare diseases. Data are sparse as it has not been a major focus in quality and research. However, there has been a recent push to study diagnostic errors more rigorously, so we do have emerging data. Diagnostic errors are difficult to measure, and we don't have great methods yet. And finally, diagnostic error is often identified after a safety event has occurred, which makes it challenging to prevent. Data about the impact of diagnostic errors can come from multiple different sources. While we have several numbers here, the incidence of diagnostic errors has been inadequately estimated. The severity of harm caused by diagnostic errors is even more difficult to estimate. Based on these sources, observational data, postmortem data, and medical records data, as well as malpractice claims, roughly 5 to 10% of adverse events occur as a result of a diagnostic error. Diagnostic errors have also been shown to be associated with a significant financial burden based on review of malpractice claims. Altogether, the evidence suggests that diagnostic errors are a significant and common challenge in healthcare. A more recent cross-sectional analysis of a large medical malpractice database found that nearly 1/3 of cases were associated with diagnostic errors. Of those cases, about 1/3 were associated with high harm, and another 1/3 were associated with death. Diagnostic error was the #1 cause associated with high harm cases, and it was also determined to be the most costly cause. Minimizing diagnostic errors for every single disease is a daunting task, but this cross-sectional analysis found that almost two-thirds of diagnosis-related harms involve diagnoses from the big three: vascular events, infections, and cancers. Nearly half of the high severity harms involve the top 5 diagnoses from each of these categories. So if we focus on just 15 diagnoses, we could potentially make a big impact on decreasing serious harm from diagnostic errors. One major challenge to addressing diagnostic error is that it's difficult to define. Many different definitions and associated terminologies are found in the literature. For example, there are different definitions for terms such as delayed diagnosis, missed diagnosis, and misdiagnosis. There's also disagreement about what constitutes a diagnostic error. Are diagnostic errors and misdiagnoses synonyms? Should diagnostic errors include unavoidable or no-fault errors? Is diagnostic error something that stems from a failure of the diagnostic process? This difficulty in defining diagnostic error likely stems from the dualistic nature of the word diagnosis. It describes both the process and the result of that process. Finally, the definition can change based on who's trying to define it. The way a patient views a diagnostic error is different from how a clinician views it, which is different from how a researcher views it. And so the definition can vary based on how they define it. To address this lack of agreement on the definition of diagnostic error and to provide recommendations for improving diagnosis, the Institute of Medicine, which is now known as the National Academy of Medicine, published Improving Diagnosis in Healthcare in 2015. It's part of their Quality Chasm series, which has the overall goal of assessing and improving the quality and safety of healthcare. One thing that the National Academy of Medicine recognized is that the diagnosis is a process, and like any process, it's prone to error. The diagnostic process is very complex. It involves many handoffs of information, it involves uncertainty, and the diagnosis may evolve over time and present in many different ways. It involves a number of participants, so patients, their family members, clinicians, and diagnostic error can occur at any point in this process. To reduce the risk of diagnostic error, we have to understand it within the context of this process. So this is the definition that the National Academy of Medicine came up with in their book. Diagnostic error is the failure to establish accurate and timely explanation of patient's health problem or problems, or the failure to communicate that explanation to the patient. It frames diagnostic error from the patient's perspective, recognizing that the patient bears the ultimate risk of harm. Here's another way to conceptualize diagnostic error, as outlined by Dr. Hardeep Singh, one of the leading researchers in diagnostic error. This diagram highlights some of the different types of error, including preventable diagnostic harm, near misses, and no-fault errors. Areas C and D could describe what is often called no-fault errors, where diagnostic error occur where there are no missed opportunities. Area A could be described what we know as near misses, missed opportunities that do not result in harm. Although we want to focus on area B, preventable diagnostic harm, in order to do this successfully, we have to work to understand the other areas. Yet another way to conceptualize diagnostic error that accounts for the complexity of the diagnostic process is to identify the broad factors affecting the diagnostic process, which we kind of alluded to when discussing our 3 cases. So we have patient factors, system factors, external environment factors, and clinician cognitive factors. Several of these patient factors, such as masked or unusual presentation of disease, complex presentation, incomplete history because of unreliability, uncooperativeness, and deception, are factors that are beyond our control. But as a system, we can make changes to decrease the delay in presentation and increase access to care. Multiple system factors affect the diagnostic process, such as policies and procedures, workflow design, coordination of care, health informatics, physical environment. There are potential interventions that could affect many of these factors and result in decreasing diagnostic error. Multiple external environmental factors exist as well, such as payment, oversight, like accreditation and certification, medical liability. Although we cannot always control these factors, we must consider them when analyzing causes of diagnostic error. And finally, we have clinician cognitive factors, such as differences in training and experience, inadequate knowledge or skills, and cognitive biases. These factors most directly and arguably most significantly affect the diagnostic process. This slide just highlights the common types of cognitive biases that have been associated with diagnostic errors. We won't go into further detail about each type of bias, as that's a separate discussion in of itself. The data from the slide comes from a systematic review of articles on cognitive biases. And as you can see, there's a wide range of percentages between the studies, which indicates a vast difference in methodology between the studies. So true prevalence is unlikely to be estimated accurately based on these studies. Yet another way to conceptualize the diagnostic process is through the SAFER diagnostic framework developed by Dr. Hardeep Singh and Dr. Dean Siddig. This framework recognizes while cognitive factors directly affect the diagnostic process, system factors and external environmental factors also affect diagnostic performance. For example, clinical productivity, legal issues, reimbursement issues, administrative demands, all can affect a provider's cognitive performance and critical thinking. This can make them prone to losing situational awareness and committing a diagnostic error. This framework also serves to refine the science of measuring diagnostic error. Measuring error can lead to better feedback on the providers on the accuracy of their diagnoses and better feedback to the health system on what missed opportunities should be focused on. In order to improve diagnostic reasoning, we need to know how to measure diagnostic error, but there are many barriers to measuring diagnostic error. We don't have a lot of data on how to assess the frequency and severity of harm related to these errors. And as we mentioned before, these errors occur in a variety of settings: inpatient, outpatient, long-term care. How do we develop tools that can be generalizable? And currently, we don't really have any good methods of measuring diagnostic error. One quality improvement study utilized the SAFER diagnostic framework to develop an analytical tool that can be used while reviewing medical records. This study found that the tool was able to detect the presence of a diagnostic error in previously confirmed cases with high accuracy and predictive value in the outpatient setting. So what are potential ways we could use this tool? It can be used to comprehensively assess diagnostic performance. We could use it with trigger algorithms to select high-risk medical records. And it can be used for learning and awareness for improvement of the practice at large. Another way to measure diagnostic error while also providing an intervention of real-time feedback is the assessment of reasoning tool developed by the Society to Improve Diagnosis in Medicine. As clinician educators at VCU here, it's important that we assess learners' clinical reasoning skills. This tool can be used to do so when learners are giving patient presentations. This tool in many ways mirrors the ACGME milestone assessments for residents discussed by Dr. Barrett and Dr. Miller at Grand Rounds a few weeks ago. So based on the milestones 2.0, we could use this tool to assess a learner at level 1 here, also known as the early learner, at level 4 here, also as residents that can be entrusted with independence, and at level 5 here, also known as the role model, coach, or teacher. Once we get a better idea of how to measure or detect diagnostic error, how do we work to reduce its incidence? Several studies have shown that the failure of clinical judgment is a significant cause of diagnostic error. Therefore, we should develop solutions and tools to address knowledge gaps and to support better bedside clinical decision-making. One study I would like to highlight was actually published by several of our own faculty from the Department of Internal Medicine, Dr. Sarah Hartigan, Dr. Michelle Brooks, and Dr. Becky Miller. In this study, they reviewed several proposed strategies to reduce cognitive error, some of which have been found to be potentially more effective than others or have unclear effectiveness in the clinical environment. They also noted that evidence of the effectiveness of many of these strategies are very limited. Even though this was published in the context of emergency medicine practice, their findings are certainly applicable to internal medicine. Techniques that reduce cognitive burden can be supported through technology, such as checklists, guidelines, algorithms, and clinical decision support are the most promising interventions that can reduce cognitive errors. So why should we use checklists? Well, we use them in medicine already. Procedures, ICUs use them frequently. But how can we apply them to prevent diagnostic error? In order to understand how checklists can be used in the diagnostic process, we must consider the dual process model, which I'm sure have been talked about at many Grand Rounds. Dual process model outlines two basic modes of thinking: the type 1, which is fast, reflexive, sometimes subconscious and intuitive, versus type 2 thinking process, which is slow, analytical, deliberate, requires focused attention. Type 1 processes are useful, but can be prone to error. And clinical work often involves type 1 thinking, especially in situations that are familiar, leading to overconfidence. In such situations, checklists could be effective. There are 3 types of checklists for diagnostic reasoning that have been described in the literature. The first one is the general checklist, which is a reproducible approach to diagnosis. It often may seem self-evident or basic, often includes obvious steps, but it prompts the clinician to optimize each step of the diagnostic process. The second type of checklist is the differential diagnosis checklist, which is a comprehensive list of diseases that could cause a symptom. It includes don't miss diagnoses and commonly missed diagnoses, so that it addresses the failure to consider the correct diagnosis. The third type is cognitive forcing checklists. They can include differential diagnoses, but oftentimes include forcing functions, which are tasks that should be done to work up a potential diagnosis. It can highlight the worst case scenarios or pitfalls. So this is an example of a general checklist. These steps seem overly basic, like obtain a medical history or perform an exam. But if they are skipped or done poorly, diagnostic errors can occur.
So our second type of checklist, which is that differential diagnosis checklist. So this was one tool that was highlighted by Michelle Brooks, which I was not aware of. It is an online tool that can help clinicians think through a case by putting in different features of the patient and generating a list of diagnoses. Unfortunately, this is not free, but it is a tool that can be used for clinicians. Really nice in that it can, you can put in the age of the patient at that left side of the screen, the gender of the patient, and where the patient is in terms of geography. And then you can free type different symptoms or complaints of the patient, and based on that can generate a checklist. And you can actually put in multiple symptoms at the same time. The checklist generates a list of the top common diagnoses based on your symptoms and the patient presentation, which is great. Those are kind of that list of likely diagnoses. But then it also has the opportunity to give you that can't miss diagnosis, the red flag symptoms, things that you really have to be thinking about. For our patient, for our first patient that had end-stage renal disease and was found to have osteomyelitis, as you can see, that spinal infection was part of that red flag can't miss diagnosis. So it is a tool that can be available to anybody, but you do have to pay for it. And then, as we all know, we are transitioning to EPIC, which has a lot of those cognitive forcing checklists that can be helpful, not so much in the diagnosis, but in the management of the diagnosis. So just to give a example of a few checklists that might be applicable to medicine. So for pneumonia, at least gives you things to think about in terms of common antibiotics that we would use rather than having to come up with things on your own, and nicely suggested I'm trying to think of the term, but suggested dosing for those antibiotics also. So can be helpful for busy clinicians. And then same thing for meningitis and for sepsis, also helping us to adhere to those bundles for different different diseases. So better is coming, and that can help us with getting into line with reducing our cognitive burden when we're trying to do a lot of tasks at the same time.
So this slide just highlights that there's no single way to reduce diagnostic errors and their associated harm. Multiple interventions working together will be the most effective way to promote change. And we certainly have many opportunities to develop additional strategies to mitigate diagnostic errors here at VCU. And these are some additional resources for everyone. The Society to Improve Diagnosis in Medicine is an excellent resource. The book Improving Diagnosis in Healthcare is free, so feel free to peruse it. And then the Isabel Differential Diagnosis Tool is linked here. All right, any questions?
Thank you both for a good presentation, good cases. Enjoyed hearing about them. Thank you for walking through that. We'd like to open it up to the audience. So you can either use the chat function, the Q&A, or raise your hand and we can unmute you. Take some questions. I have a question. I can go ahead and get started, I guess. So on the individual clinician side, I think the question is oftentimes in root cause analysis or retrospective reviews, it might be easier to identify some of these things. So you mentioned the checklist, having a standardized approach to assessing a patient, history, physical exam, labs review, all of the things that we regularly do. I think one of the issues sometimes for individual clinicians may be an unrecognized bias. So, if I think I'm seeing patients and I've seen this problem, 300 times, what do I do to kind of check myself at the door or pause, before I go in and see that patient? Do you have any tips on best ways to incorporate that? Maybe we could just imagine that you're in a busy clinic and you're about to go in and see somebody, a 10-second pause before you walk in the door. What do you suggest?
Yeah, so I think you hit the nail on the head, and we didn't delve into that, those biases specifically here, because that can be a whole hour talk in and of itself. But really to uncover those unconscious biases, I think, are important. I think, as you said, the kind of that pause before you enter in the room is an important piece to think about, to kind of reflect on what you're seeing. And rather than to use that type 1, I've seen this 1,000 times before, this is my this is a duck, acts like a duck, that kind of stuff, but really to consider what might be the opposite, or to apply that type 2 thinking. So just to look at those pieces of data to ensure that you're really thinking about this from an analytical standpoint, rather than I've seen 10 of these before, and of course this is number 11. Carol, I don't know if you have any other thoughts.
Yeah, I think you hit the nail on the head as well. I think the pausing to reflect step in this general checklist kind of reflects that. Using perspective hindsight, it's like predicting what would happen if your diagnosis was wrong, or if your diagnosis was correct. So that can help too. But there's still a lot of work to be done to study this more. I think a lot of and Dr. Hartigan's paper highlighted that a lot of these these tools that we are talking about haven't really been, like, there's not a lot of evidence to support their effectiveness. But I think it just needs more study.
There was a question in the, thank you so much for answering that. I appreciate the response. There was a question in the Q&A from Alan Dow. And so these patients seem to have a lot of transitions between teams or consultants. Do you commonly see this as problematic? Thoughts about how to mitigate the dangers around these transitions? And Dr. Dow, if you want, I can unmute you if you have further clarification, but we'll turn that over to our speakers. Thank you.
Yeah, I think that that's a really common, and I think it's going to be continued to be common, especially as our patients are as complex as they are. I think a good way to approach this, and something that I at least try to do myself, is to not use the information that was given to me and to just kind of start from scratch. It's kind of that first thing that we teach in medical school for our learners, but I think it still applies because it's very easy to create a picture based on small pieces of information that somebody has packaged for you, right? That premature closure, or even sometimes a hassle bias in terms of they've told me this, it's harder for me to look at other things, and so I'm going to really focus on this as my top differential. But really to obtain that history for yourself to confirm what you've been told, I think is important. And then, of course, increasing communication is always going to be helpful. But thank you for that question, because I think it's definitely something that we see, and that was common with all of these cases.
Thank you. We have a question in the chat box here from Patrick Fadden. I think we could all do a better job of following up on cases to have better understanding of outcomes, becoming better calibrated in our diagnostic approach. Any comments on that?
Yep, I agree, and I think that's one of the things that we haven't been great about doing in terms of medicine. One thing that I remember seeing a previous speaker speak about was, those patients that you have just an inkling about, maybe there was something that was different, or I want to follow up on that patient, to keep a list of those diseases, or excuse me, not the diseases, but a list of those patients, just so that you can follow up after you've handed them off to a different service or a different provider, because those are the ones that stick in our minds, and those are the ones that we will learn from, more than the ones that were the common, that things went exactly the way that you thought that they were going to go. It's those ones that you have that kind of intuition about and follow up, and if something didn't go the way that you thought it would, those are the ones that you're really going to learn from. So just to keep that list of cases that you can look up in the future, I think is a good practice for all of us, for that reflective practice.
Yeah, I think it is quite challenging to do that in our current climate, where there's a lot of handoffs and not a lot of consistency with providers. But I agree. I think being more mindful about the patients that we're seeing, and not forgetting about them after you've rotated off a service is important.
Thank you. We have one question in the Q&A box from Renee Carter. What modes of communication would you suggest will lessen diagnostic errors? Verbal versus portal messages, patient clinical note? Do you know if there will be any improvement with Epic? Any thoughts?
That's, I think, a really good question. I don't know that I have a clear answer about the communication mode. I think overall, just increased communication is better, whether it's written or verbal. From what I've been told, Epic does have an improved way to identify a patient's care team or their medical home. especially their primary care providers, so that we can increase that handoff from service to service or from settings. But I don't know that I have any one answer in terms of how to improve communication rather than just to do it. I don't know if you have any thoughts.
I think even though it can be burdensome, verbal interactions are probably the most effective compared to written communications, but it is burdensome. So to figure out how to make it less time consuming, it will be a real challenge.
Thank you for these questions. These are all things that we've been thinking about and practice every day and are challenged with every day. Any other questions?
I guess that's it in terms of questions. Dr. Syme, do you have any questions or thoughts?
Yeah, Georgia, I was going to just ask you what your thoughts are on the best way to sort of educate our learners with these kind of safety medication errors. Given that I think Carol's right, it's sometimes a bit positive data how best to do this, but obviously it's really important that the learners who are, the attendees of tomorrow are really well versed in this. I wonder if you have any specific thoughts. I know we have residents and fellows do quality projects, but have any specific thoughts around this?
Yeah, I think that, it is can be time consuming for educators, but I always think of those cases when I've been in the inpatient setting that maybe something didn't go the way that I thought it should. And sometimes I do reach out to the team just to say, hey, do you remember patient X? They actually had this, this thing happen to them afterwards, which we didn't necessarily anticipate. But again, those are the cases that that stick with me. And I think doing that in a objective way so that people can recognize the kind of the trigger signs or those red flag signs that we shouldn't miss in the future helps everybody to learn and takes the subjective nature out of it to really make it a objective learning case. So I think that reflective piece, I'm not always good about it, but I think it's always helpful to reflect on things that could be done in the future.
Well, thank you all so much. Don't see any other questions right now, but thought that was a really good 10-minute conversation here. So I appreciate that. And so I want to thank our speakers, Dr. McIntosh and Dr. Marcelo. This is the end of the Department of Internal Grand Rounds. We will put the code back on, as well as the new innovations for attendance. But thank you both to both of you. We appreciate your time and dedication and commitment to this hour and preparing. So thank you so much. Appreciate it. We'll stay live for a few minutes to make sure people can submit the code. Thank you.
Thank you.
Thank you.